intraoperative considerations, fluid management, neuraxial anesthesia. Definition of children is up to 12 years. Infant is up to 1 year of age or 12 months. Full term gestation is after 37 weeks. Preterm gestation is before delivery before 37 weeks. Neonate is up to 28 days. Early neonate is 0 to 7 days. Late neonate is 7 to 28 days. So early neonate is 0 to 7, late neonate is 8 to 28. How do they differ from adult population in anesthetic management? The position of the larynx in adults is interspace between C5 and C6. In children at the age of 6 is interspace between C4 and C5. In infant, it is at midpoint of the third cervical vertebra. Glottic opening relative to cervical vertebra in adults is the interspace between C5 and C6. In children at the age of 6 is between C4 and C5. In infant, it is midpoint of the body of the third cervical vertebra. Differences between pediatric and adult airway, supraglottic. Nares are narrow in pediatric population. In adults, it's wide. Angle of the jaw is obtuse in pediatric patients. In acute in adults. Relatively larger size of the tongue in pediatric population. Non-ossified palate in pediatric population. Epiglottis large, floppy, mega shaped in pediatric, omega shaped in pediatric population. Vocal cords are anterior slanting. Array epiglottic folds are thicker and difficult to fix the laryngoscope blade. Submucosal tissue are more increased chances of edema. So quickly review the differences. Relatively large size of the head, small size of the mouth, large size of the tongue, anterior slanting vocal cords, thicker array epiglottic folds. Subglottic differences. The cartilages are soft, collapsible easily in pediatric population, whereas in adults, cartilages are harder and stable. The lumen of the glottis is circular and narrow in pediatric population, whereas in adults it is wide and elliptical. Subglottis is funnel shaped in pediatric population. Cricoid is narrow before puberty and it is wide in adults. The narrowest part of the airway in pediatric population is subglottis, whereas in adults it is vocal cords. Length of the trachea is 4 centimeters in pediatric population, whereas it is 12 centimeters, 12 to 13 centimeters in adults. Angulation of the bronchi is more horizontal in pediatric population, less horizontal in adults. Relatively, the diaphragm is higher in pediatric population, whereas it is lower in adults. Ribs are horizontal in pediatric population, whereas they are slanted in adult population. The number of alveoli is 20 to 50 millions, lesser in pediatric population. It is 300 millions in adults. So narrowest part of the airway is subglottis, whereas it is vocal cords in adults. Diaphragm is relatively high. Ribs are horizontal. Number of alveoli are less in pediatric population. Physiological changes. Cardiac output in pediatric population is rate dependent, heart rate dependent. So they have higher heart rate and lower blood pressure. They also have respiratory rate is more, lower lung compliance, and greater chest wall compliance. Quickly, we see the respiratory rate in neonates is 40, whereas heart rate is 140, blood pressure is 65/40. At the age of 1 year, the respiratory rate is 30 and heart rate is 120, blood pressure is 95/65. At the age of 12 years, respiratory rate is 20, heart rate is 80, blood pressure is 110/60. So heart rate and respiratory rate decreases from neonate to child, whereas blood pressure increases from neonate to child. At the time of birth, respiratory rate is 40, heart rate is 140, blood pressure is 65/40. At the age of 12 years, respiratory rate is 20, heart rate is 80, blood pressure is 110/60. In pediatric population, FRC is low, and ratio of the body surface area to body weight is high. Higher total body water content. They have predominant parasympathetic activity. Sympathetic activity is less developed. The fetal circulation, prenatal and postnatal. Prenatal, in postnatal, there is obliteration of the foramen ovale, ductus venosus, and ligamentum arteriosum, and umbilical arteries. In prenatal, there is right to left shunts. At the various stages of the postnatal life, all these communications becomes obliterated and right to left shunts is obliterated. In cases of hypoxia and acidosis, when there is an increased pulmonary artery pressure, these shunts may open. Cardiovascular system, neonatal myocardium contains 30% less contractile tissue and more connective tissue than adults. Ventricles are less compliant, they are less contractile, so they cannot increase the stroke volume. Sympathetic innervation is incomplete and stores of adrenal are inadequate. So vagal component is high and bradycardia is common. Inactive baroreceptors, so they find difficult to maintain cardiac output. Hypoxia, acidosis, sepsis, pulmonary artery hypertension, hypothermia, all these causes reversal of fetal circulation. Cardiac calcium stores are reduced because of immature sarcoplasmic reticulum. Neonates have high greater dependence on exogenous calcium, more susceptible to myocardial depression by potent inhalation agents that has calcium channel blocking activity. Functionally, cardiac output is the product of heart rate and stroke volume. Stroke volume in turn dependent on myocardial contractility, preload and afterload. Low compliance limits preload determining the stroke volume. Afterload is determined by the peripheral vessel tone. Afterload is low in neonate because of the poorly developed sympathetic tone. Hypoxia is a major cause of bradycardia in neonate. Chest is circular and ribs are horizontal in neonates, whereas ribs are vertical in adults. Ribs and cartilages are more pliable. Chest wall compliance increased. Alveoli are small and limited number. Lung compliance decreased. Airway resistance is increased as per the Poiseuille's law. Atelectasis is common in pediatric patients. Developmental changes of the rib cages and diaphragm from birth to adult. This is a diagram showing the differences between the chest in newborn and adult. Adults can increase lung volume by raising the ribs, contracting the diaphragm, early in the development, the configuration of the rib cage and the muscular attachments of the diaphragm place the newborn at a mechanical disadvantage because ribs are already raised and contraction of the diaphragm results relatively small increase in the thoracic cavity volume. You can see small increase in the thoracic volume in pediatric patient, whereas in adults by contraction of the diaphragm, there is a relatively large chest volume increase. This is a diagram showing the cut section of the alveoli. In infant, it is 4 millimeter size. In adults, it is 8 millimeters size. So when there is a edema of 1 millimeter, as per Poiseuille's law, which states that the radius is proportional to, or inversely proportional to, fourth power of the radius, as the cross-sectional area decreases by 7%, 75% in units. 1 millimeter of edema decreases the cross-sectional area of the alveoli by 75%, whereas 1 millimeter of edema in adults will decrease by cross-sectional area only 44%. Neonates and infants have limited respiratory reserve. Ventilation is mainly diaphragmatic. Bulky abdominal organs limits movement. The ratio of alveolar ventilation versus functional residual capacity in adults is 1.5 is to 1, whereas in children it is 5 is to 1. The diaphragm of the neonates contains fewer type 1 muscle cells and it is easily fatigable. Low residual lung volume at expiration, FRC, overlaps the closing capacity, causing atelectasis. In pediatric population, oxygen consumption is high due to higher minute ventilation and higher blood flow to the vessel-rich group. In conditions like general anesthesia, apnea, FRC decreases by 10% of the total lung capacity. Uneven distribution of ventilation and increase in physiological dead space. So to maintain FRC, addition of PEEP of 5 centimeters of water, start with a tidal volume of 10 to 15 ml per kg and a respiratory rate of 30 breaths per minute in infants. Infants are prone to perioperative hypoxemia because of their immature respiratory control and irregular breathing. Hypoxia does not stimulate, but rather depress ventilation. Infants have high oxygen demand and small and decrease in FRC because of anesthesia. Anesthesia reduces FRC, airway closure, and result in atelectasis. The high affinity, low oxygen unloading of the fetal hemoglobin, HVF. And coming to the central nervous system, brain is incompletely myelinated, blood-brain barrier is immature at birth. 1/3 of the total cardiac output perfuses the brain in neonate. Cerebral blood flow is 30 to 40 ml per 100 grams per minute in pediatric population, whereas in adults it is around 55 ml per 100 grams per minute. Cerebral blood flow in autoregulation is present in newborns, but it is tenuous. Cerebral vascular response to changes in PaCO2 and PaO2 are blunted in neonates. Neonates are vulnerable to cerebral ischemia and intraventricular hemorrhage because of the narrow autoregulatory range. So, tight blood pressure control is essential in the management of neonates to minimize cerebral ischemia and during hypotension and intraventricular hemorrhage. This is a diagram showing the mean arterial pressure in x-axis and cerebral blood flow per ml per 100 grams per minute in y-axis. Autoregulation in adults is between 50 to 150 MAP, whereas in neonates, the lower limit of the autoregulation is 30 mm, whereas the higher limit is not developed in pediatric or neonates. So we should be very careful, and tight blood pressure control is essential in uh, neonates and pediatrics. The implication of body composition in neonates. A water-soluble drug has a large volume of distribution, so increase in dose is needed. Due to less fat, the action of the drug is prolonged. Maintenance fluid therapy for a hospitalized neonate and infant based on the method of Holiday and Sagar. Initial first 10 kgs of weight, 4 ml per kg per hour. Next 10 to 22 ml per kg per hour. More than 20 kg, 1 ml per kg per hour. And this should be addition of third space fluid replacement. How to calculate third fluid space requirement? Probability of fluid translocation little or no in surgeries like tympanostomy, tube placement. Addition is not required. Whereas in mild surgeries like inguinal hernia, 2 ml per kg per hour should be added to the maintenance fluid. Moderate surgeries like thoracotomy, 4 ml per kg per hour. Severe surgeries like bowel obstruction and bowel resection, 6 ml per kg per hour should be added to the maintenance fluid. Glucose management. High glucose utilization in neonates, 3 to 4 milligrams per kg per minute. Low glycogen stores. So neonates less than 30 milligrams per deciliter. So as soon as the baby is born, when you check a blood sugar level, if it is less than 30 or 40 milligrams per deciliter, you should supplement glucose. Renal system. Renal function is decreased in neonates because of the low perfusion pressure and immature glomerular and tubular function. Complete maturation of the renal function takes place by about 2 years of age. Glomerular filtration rate reaches 30% of the adult in neonate. Immature erythropoietin production up to 3 months. So they are more prone for anemia. Thus, the ability to handle free water and solute loads may be impaired in neonates, and the half-life of medications excreted by means of glomerular filtration will be prolonged. Example, antibiotics. Hence, longer interval between the doses is required in neonates because of the immature glomerular and tubular function. Liver. A preterm infant's liver has a minimal glycogen stores and is unable to handle large protein loads. This accounts for the neonate's tendency towards hypoglycemia and acidemia. Plasma levels of albumin and other proteins necessary for binding of drugs are lower in full-term newborns and are even lower in preterm infants than in older infants. The condition has a clinical implication regarding the neonatal coagulability, the need of vitamin K at birth. Hematological, at birth, hemoglobin is 19 grams per deciliter, represented by HbF. Physiological anemia of infancy, at 2 to 3 months of age, the HbF is replaced by HbA. HbF has a high affinity for oxygen and limits oxygen unloading at tissue level. And also there is a shift of ODC curve, HbF leftward shift of the ODC curve. Decreased oxygen delivery to the tissues that have higher oxygen demand than those of adults. Thus, neonates are prone to perioperative hypoxemia, tissue hypoxia. Thermoregulation. Neonates lose heat by evaporation, convection, conduction, radiation. To compensate for the losses, sympathetic system constricts skin blood vessels. Cold stress will result in increased oxygen consumption and can cause metabolic acidosis and increased pulmonary and peripheral vascular resistance, reducing cardiac output. Infants are especially vulnerable to hypothermia because of large ratio of body surface area to weight, the thinness of the skin, limited ability to cope up with cold stress, reduced subcutaneous fat. They compensate by means of shivering and non-shivering thermogenesis. Prematurity and general anesthesia aggravates neonate poor metabolic response to hypothermia. Hypothermia increases pulmonary vascular resistance, decreases pulmonary blood flow, causes right to left shunting of the blood. Shivering is limited by smaller muscle mass. The minimal ability to shiver during first 3 months of life makes cellular thermogenesis, metabolism of brown fat, the principal method of heat production. Brown fat is found in between the scapulae and above the major abdominal organs like adrenal. Non-shivering thermogenesis is due to stimulation of the triglyceride and fatty acid metabolism in energy-rich brown fat by norepinephrine and thyroid hormone. So, the method of thermogenesis by two methods. One is shivering and other is non-shivering. Non-shivering is metabolism of the fatty acids by norepinephrine and thyroid, whereas shivering is by cellular thermogenesis by metabolism of the brown fat, which is found in between the scapula and supraadrenal. Placing the baby, how to prevent? Placing the baby on a warming mattress and warming in the OT, 80-degree Fahrenheit or warmer to reduce the heat lost by conduction. Keeping the infant in an incubator covered with blankets minimizes heat loss through convection. The head should also be covered because head is larger than the relatively larger in newborns. Heat lost from radiation is decreased with the use of double-shelled isolate during transport. Heat loss through evaporation is lessened by humidification of the inspired gases. Anesthetic agents can alter many thermoregulatory mechanisms, particularly non-shivering thermogenesis in neonates. So, physiology of the neonates is over. Now we are going to preoperative. PAC history, weaning from parents. Intraoperative, IV cannulations, drugs and equipment, fluid management, monitoring. Post-operative, analgesia, prevention of complications. Preoperative evaluation, the informant will be either the mother or the relative. He should elicit history of present illness, associated medical problems, any congenital anomalies, antenatal history should be elicited, birth history, birth trauma, forceps use, and immediate postnatal history should be elicited. History of consanguineous marriages and similar complaints in siblings, history of cold, cough, fever, running nose, recent respiratory illness should be noted. Immunization history, history of allergies should be noted. Preoperative considerations, medical and anesthetic history, weight you should always note the weight of the baby and also vitals, any congenital abnormalities, immunization history, drug history, investigations and risk assessment. You should inquire about the history of seizures and also the medications used for seizures because of the drug interactions, and whether the seizure occurred due to inadequate anticonvulsant therapy and drug-induced hepatomegaly. You should also inquire about any head trauma, hydrocephalus, central nervous system, tumor, because all these things will cause elevated intracranial pressure. History of any delay in the developmental milestones because of the bulbar dysfunction. You should suspect bulbar dysfunction and the risk of aspiration if there is a developmental delay. History of neuromuscular disease because in these patients there will be altered response to muscle relaxants. Any history of myopathy, you should be elicited as there is a risk of malignant hyperthermia in these patients. During cardiovascular system examination, you should hear about the heart murmurs, history of sweating, diaphoresis with feeding or crying, any history of hypertension. Heart murmur because of right to left shunt, fear of air embolism, and if there is a history of prosthetic valve, the need for SBE prophylaxis. History of squatting denotes tetralogy of Fallot. Diaphoresis with feeding or crying, the suspicion of congestive heart failure. History of hypertension, you should suspect coarctation of aorta, pheochromocytoma, renal disease. History of prematurity, there is increased risk of apneic spells in the postoperative period in case of premature. Bronchopulmonary dysplasia, you should suspect pulmonary hypertension. If there is history of a running nose, cough, there is a possibility of bronchospasm. If the newborn is having croup, you should suspect subglottic stenosis. If there is a snoring, you should suspect obstructive sleep apnea. History of asthma, you should elicit theophylline therapy, beta agonist therapy, history of steroid use. If there is already having a diagnosis of cystic fibrosis, you should think of the pulmonary dysfunction and VQ mismatch. Gastrointestinal system, if patient is having vomiting and diarrhea, you should always inquire order for electrolytes and see for electrolyte abnormality. If there is a history of growth failure, there is a risk of hypoglycemia and low glycogen reserves. History of gastroesophageal reflux, there is a risk of aspiration. History of jaundice, altered metabolism in the liver, and a prolonged action of the anesthetic drugs. If there is a history of liver transplant, patient may be having immunosuppression. History of frequency and nocturia, suspect occult diabetes mellitus. If there is a history of dialysis or renal failure, it should elicit for any electrolyte disturbances, hypervolemia or hypovolemia. History of kidney transplant, suspect immunosuppression. If there is a history of juvenile diabetes, you should assess insulin requirement and intraoperative hyper and hypoglycemia. History of steroid therapy, suspect adrenocorticoid suppression. Hematological anemia is there. It may be occult sickle cell disease, or the baby may require transfusion intraoperatively or postoperatively. History of bruising and bleeding, suspect coagulopathy. If the patient is a known sickle cell, it should also required for hydration, need for hydration, and tourniquet is not advised in these patients. Human immunodeficiency virus infection, susceptibility to infection, history of loose primary teeth, risk of aspiration of the avulsed tooth. General examination, look for activity of the baby, cry, color, hydration status. Between ages of 4 to years, examine for loose primary teeth, any enlarged cervical nodes, any discharge from the ear to suspect otitis media. Look for IV lines, spine examination. Systemic examination should be done routinely. Children must be weighed. All drug doses relate to body weight. Examine the airway. Inspect the general appearance of the head and face, including neck. Following factors are the indicators of difficult airway: abnormal shape of the head, microcephaly or hydrocephalus, dysmorphic facial appearance, presence of cleft lip or palate, receding mandible or retrognathia, presence of neck swelling, cystic hygroma, cervical encephalocele, CBP, electrolytes, coagulation profile, chest X-ray, cardiac evaluation, urine analysis. Fasting guidelines. Infants and young children have a higher metabolic rate and a large body surface area in relation to the weight than adults and become dehydrated more easily than adults. The NPO guidelines for elective surgery in infants and children. Clear liquids. Minimum hours of fasting is 2 hours. Breast milk, minimum hours of fasting is 4 hours. Citrus juice, milk or commercial milk formulas, milk and milk products, NBM is 6 hours. For solid food, minimum hours of fasting is 8 hours. Pre-medication. Sedative pre-medication is generally omitted for neonates and sick infants. Children who are likely to exhibit uncontrollable separation anxiety may be given a sedative such as midazolam, 0.5 milligram per kg, up to a maximum of 15 milligrams orally. The oral route is generally preferred because it is less traumatic than IM injection, but it requires 20 to 45 minutes for effect. Smaller doses of midazolam have been used in combination with oral ketamine. Uncooperative patients, intramuscular midazolam 0.1 milligram per kg to a maximum of 10 milligrams. Ketamine 4 to 10 milligrams per kg with atropine 0.02 milligrams per kg may be helpful. Intramuscular 0.1 milligram per midazolam, ketamine 3 to 10 milligrams per kg, atropine 0.02 milligram per kg. Some administered dexmedetomidine 1 to 2 micrograms per kg intranasal or midazolam intranasally. Fentanyl can also be administered as a lollipop 5 to 15 micrograms per kg. Atropine may be administered orally 0.05 milligram per kg or IV 0.02 milligrams per kg to prevent accumulation of the secretions. Intraoperative considerations: room temperature, table, workstation, airway equipment, suction, IV access, drugs, and fluids. Always remember to change the profile on the monitor to pedi or neonate as appropriate. How to select the size of the endotracheal tube? There is one formula called Pendleton's formula. This formula states that age is less than 6 years, age by 3 plus 3.5. If age is greater than 6 years, age by 4 plus 4.5. You can also measure the diameter, select the size of the ET tube by measuring the diameter of the distal joint of the index finger of the child or lumen of the external nares. LMA sizes: 10 kgs LMA is 2, 20 kgs 2.5, 30 kgs 3. Rough remembrance: 10 kg 2, 20 2.5, 30 3 kgs. For 2 size LMA, you have to inflate cuff 10 ml, 2 and of 14 ml. For 3 size LMA, 20 ml volume of the air should be inflated. Breathing circuit. Mapleson F or Jackson-Rees modification of the IRTPs is a basic system for use with pediatric patients. This is the circuit of choice for children less than 6 years or below 25 kg of body weight. But presently, most of the OTs they are using pediatric vein circuit. Suction catheter. Diameter of the catheter should be less than half or one-third inner diameter of the suction catheter. Infants 6 to 8 French, 2 to 6 years 10 French, 7 to 15 years 12 French. Monitoring. Alarm limits should be adjusted. Pulse oximetry, ECG, BP, precordial stethoscope, which is very important in pediatric patients. Temperature, ETC, O2, random blood sugar, urine output, blood loss. Remember to change the profile on the monitor to pedi or neonate as appropriate. Inhalational induction. Many children do not arrive in operating room with intravenous lines in place. Children who have been sedated prior to entering the operating room and who are sleepy enough to be anesthetized without ever knowing what has happened. This is called steal induction. Typically, the child can be coaxed into the breathing odorless mixture of 66% nitrous oxide with 33% oxygen. And sevoflurane can be added to gas mixture in 0.5 percent increments every few breaths. Desflurane and isoflurane are avoided because they are pungent and are associated with more coughing, breath holding, and laryngospasm. Appropriate MAC values for pediatric patients. Halothane MAC value in adults is 0.75, whereas in infants it is 1.1 to 1.2. The MAC value of sevoflurane in adults is 2, whereas in infants it is 3.2. Isoflurane MAC value is 1.2 in adults, whereas it is infants 1.8 to 1.9. MAC value of desflurane in adults is 6, whereas in infants it is 9 to 10. After adequate depth of anesthesia is achieved, an intravenous line can be started and opioid and propofol are administered to facilitate intubation. Alternatively, deepen the level of anesthesia by increasing the concentration of the volatile anesthetic and then place a LMA or intubate the patient under deep sevoflurane anesthesia. Disadvantage of deep lane technique, there is an increased risk of cardiac depression and bradycardia. Induction in infants of 10 to 12 months age. Mask induction without premedication, allowing neonates and small infants to suck on a rubber nipple or on a gloved finger generally prevent crying during induction. Induction in older pediatric patients, inhalation or mask induction techniques, using a flavored mask, play a game technique, single breath technique. Intravenous induction, same technique can be used as in adults. Atropine 0.02 milligrams per kg should be given. Induction agents, propofol 2 to 3
हेलो।
सर सुनाई नहीं दे रहा है सर।
రమణ ప్రసాద్ ఏం వినపట్లేదు.
నెట్ కనెక్షన్ బ్రేక్ అయినట్టుంది సార్. లెఫ్ట్ అయ్యి ఇప్పుడే మళ్ళీ రీజాయిన్ అయ్యారు. సార్ అన్మ్యూట్ చేసుకోండి. రామ్ ప్రసాద్ సార్ మ్యూట్ లో ఉన్నారు.
రమణ ప్రసాద్ గారు మీ మాట వినపట్లేదండి. నువ్వు తీసుకో కంట్రోల్ శ్రీకాంత్, లేకపోతే అది పీపీటీ, అది ఇండియన్ వాళ్ళ అబ్బాయి ఉన్నట్లేడు, వెళ్ళిపోయినట్టున్నాడు.
ఓకే బట్ హలో సార్, రామ్ ప్రసాద్ సార్.
అయింది సార్. కాదు, రావు స్లైడ్స్. సార్ ఇక్కడి నుంచేనా సార్? సార్ మీరు ఇంట్రామస్కులర్ ఇండక్షన్, am I audible, sir?
Yeah, you're audible. Please go ahead.
Ketamine intra 4 milligrams per kg combined with atropine 0.02 milligrams per kg, midazolam 0.5 milligrams per kg. Advantage, reliability, and disadvantage is painful. Muscle relaxants, non-depolarizing agent, atracarium 0.5 milligrams per kg, cis-atracarium 0.15 milligrams per kg are usually preferred. For rapid sequence intubation, succinylcholine, in infants it is 2 to 2.5 milligrams per kg or 4 to 6 milligram per kg IM. Rocuronium 0.6 to 1.2 milligram per kg. tracheal intubation. The infant's prominent occiput tends to place the head in a flexed position to intubation. This is easily corrected by slightly elevating the shoulders on a towels or placing the head on a donut-shaped pillow. In older children, prominent tonsillar tissue can obstruct visualization of the larynx. Straight laryngoscope blades and intubation of the anterior larynx in neonate infants and young children. What is the disadvantage of using a straight laryngoscope blade or Miller blade? Any of the students can tell. The posterior surface of the epiglottis. When we use a straight laryngoscope blade, we will usually include the epiglottis. So the posterior surface of the epiglottis is innervated by vagus. So the possibility of causing bradycardia is more with straight blade. Correct tube size and appropriate inflation is confirmed by ETCO2. Anesthesia can be maintained in pediatric patients with the same agents as in adults. You can reversal dosage is atropine 0.02 milligrams per kg combined with neostigmine 0.06 milligrams per kg. Ventilatory settings. Pressure limited mode should be used for neonates, infants, and toddlers. For children less than 10 kg, adequate tidal volumes are achieved with a peak inspiratory pressure of 15 to 18 centimeters of water. For elder children, volume control ventilation should be used with the tidal volumes, lower tidal volumes such as 6 to 8 ml per kg. This is a diagram showing in supine position, the relatively large size of infant head results in natural neck flexion, compressing the soft upper airway passages. Simply extending the neck is sometimes all what is necessary to bring the patient in good sniffing position. More often, a combination of the headrest and a shoulder roll becomes necessary to bring the nose-chin axis in horizontal to the ceiling. So shoulder roll should always be placed behind the shoulder in case of neonates and infants. The thumb and index finger, how to hold the mask firmly on the face. Masking technique by single hand. Claw your fingers, little ring and middle fingers to focus your hold on the mandibular body, avoiding pressure over the submental area. Fluid requirements. In dextrose half normal saline, 5% dextrose, 0.45% normal saline. It is the type of fluid used usually. In our institute, they also add 5 milliequivalents of potassium chloride to this solution. Dextrose half normal saline is usually practiced to avoid the risk of hypoglycemia. As already we told, this is a repetition of the holiday Sagar school, most important 4-to-1 rule to estimate the maintenance hourly fluid requirement. First 10 kg 4 ml per kg per hour. Next 10 kg 2 ml per kg per hour. Next 10 kg more than 20 kg 1 ml per kg per hour. A 25 kg child would require 65 ml per hour. This does not include fluid deficits, third space losses, modification as per to hypothermia or hyperthermia, and requirements caused by unusual losses. So third space losses are also replenished according to the surgical procedure, 0 to 2 ml per kg per hour for a minor surgical procedure and 6 to 10 ml per kg per hour for major abdominal procedures. Third space loss should always be added or supplemented to the hours of fasting fluid calculation and maintenance fluid. Post-operative fluid management should be reduced to 1.5 formula. After 12 hours of the child unable to convert to oral intake, the standard hypotonic solution, dextrose D5 and 0.45% saline is initiated at the 4-to-1 rule. As the 4-to-1, if you continue 4-to-1 rule, there is a risk of hypernatremia in the after 12 hours. So you should reduce post-operative to 1.5 rule. This is the most important point. Maximal allowable blood loss, MABL. How do you calculate MABL? First, you should calculate estimated blood volume. Estimated blood volume in a term unit is 80 to 90 ml per kg. More than 6 years of the child, it is 65 to 75 ml per kg. So, to calculate MABL, first you should know estimated blood volume. It varies anywhere between 70 to 100 ml per kg as per the age of the child. MABL is equal to weight of the child into estimated blood volume into starting hematocrit H0 minus lowest acceptable hematocrit H1 by average hematocrit. MABL is equal to weight of the child into estimated blood volume into initial hematocrit minus lowest acceptable hematocrit divided by average hematocrit. Intraoperative blood loss, the replacement of blood is done with crystalloid 3 ml per 1 ml of blood loss, colloid 1 ml per 1 ml, and packet cell 0.45 ml per 1 ml of the blood loss. Crystalloid 3 ml per 1 ml, colloid 1 ml per 1 ml, packet blood cell 0.5 ml per 1 ml. Post-operative care of the pediatric patient. Post-operative, you will take care of the PONY with a combination of antiemetic 5H3 antagonist with dexamethasone 1 milligram per kg. Post-operative pain relief, paracetamol rectal suppositories 20 milligram per kg or intravenous more than 2 years 15 to 20 milligrams per kg. Caudal analgesia. In pediatric population, for sacrolumbar block, 0.5 ml per kg of 0.25% bupivacaine. Sacrolumbar block, the dose is 0.5 ml per kg of 0.25% bupivacaine. The average volume of the sacral canal in adult is 30 to 35 ml. Spinal anesthesia. The spinal cord normally extends from foramen magnum to the level of L1 in adults and L3 in children. So, performing a lumbar puncture below L3 in a child avoids potential trauma to the spinal cord. The coverings via arachnoid dura extend up to S2 vertebra. The dose of bupivacaine in pediatrics. 0.1 ml per kg for infants weighing 0 to 5 kg, 0.08 ml per kg in 5 to 15 kgs, 0.06 ml for child weighing 15 kg and above. So less than 5 kg, 0.1 ml per kg, 5 to 15, 0.08 ml per kg, more than 15 kg, 0.06 ml per kg. Thank you.
Thank you so much, sir. Sir, first of all, wonderful PPT అసలు చాలా బాగా అంటే lot of efforts put into that preparing the PPT definitely very much useful for students and also those who are actively practicing pediatric cases for anesthesia. So now anyone doubts, questions, students? DNB students and young consultants, lot of them joined. Vamsi, working in VMC with pediatric cases.
If you secure IV access in a chubby child, 50% of your work is over. Securing IV access in a chubby child is a most difficult task.
Hello, sir. Good morning, sir.
Good morning, sir.
Sir, this is Omkar, sir. Sir,
Sir.
apart from murmur, sir,
Sir.
if baby is having acceleration and deceleration in heart rate, if you are observing for 1 minute, what do you call heart rate, sir? Any what do you call further investigation we need to do, or can we continue, sir? Sinus rhythm. Yes, sir. For kids, especially less than 5 years, 30% of people, kids will have accelerations and decelerations in their heart rate.
With respiration.
Sir. Because we cannot ask them to hold their breath. So acceleration, decelerations are always present.
Yes, sir.
So what to do next, sir?
You can go ahead, I think. Yes. Because variation of heart rate with respiration is common in children.
And to confirm that it is varying with respiration is also a bit difficult, sir, because the respiratory rate will also be high. So 1 minute heart rate, if you are observing, few cases where initially when I observed acceleration and decelerations, so 1 or 2 cases I went for 2D echo, sir.
Okay.
So then cardiologist suggested that acceleration, decelerations in less than 5 years, you can go ahead. But the reason for this is one is respiration, because of respiration, and other reasons in case because with small kid we cannot correlate breathing with heart rate. It's not that easy. So any other assessment thing, sir, to say that it is means because of only respiration. Any other thing can I do?
Sir, first you should, if there is a irregular RR variation,
Sir.
the calculation of there is a regularly we number of R's in by 300, 300 by number of R's present.
Yes, sir.
Calculate the rate. But
Yes.
RR variation is there. There is another formula. I do not remember exactly. If anybody knows, they can tell. ECG, if there is a irregular R rate, RR variation, formula varies to calculate heart rate.
For RR variations, sir?
Yes, sir.
But especially in daycare procedures, where most of the time we don't do ECG, sir. For especially in Vijay Medical Center, where we do daily
ఏ సెంటర్ అయినా సరే ఓంకార్ చాలా వరకు రూల్ అవుట్ ప్రకారం కూడాను మనం మొన్న చెప్పారు కదా PSC లో అవసరం లేదని చెప్పారు కదా.
అదే సార్, అదే యాక్సిలరేషన్ డిసెలరేషన్స్ అనేవి చాలా కామన్ గా తగులుతాయి సార్. ఎవ్రీ 5th కేస్ వీడు యాక్సిలరేషన్ డిసెలరేషన్స్ ఉంటాయి. అంటే అది అంటే అక్కడే మనకి కార్డియాక్ పీడియాట్రిక్ కార్డియాలజిస్ట్ మేడం ఉన్నారు ఒక ఆవిడ. So we discussed with her, and finally acceleration decelerations can be taken for granted అనేది అక్కడ. So if we are dealing with any tonsil case for 5 years or 6 years, so అప్పుడైనా సరే should we go for 2D echo or cardiology consultation or not for a baby?
If you do not hear any murmur,
Okay, sir.
And the acceleration decelerations are regular, and
Okay,
the age
sir.
of the child is less than 5 years, and the operation is a short procedure, I think
Okay,
you need not go. But But for prolonged operations like ENT operations, where they take 2 or 3 hours, uh, you have to go for TDU.
Thank you, sir. Thank you.
Thank you. Srikant sir. Hello.
Sir, ఒక్క 2 minutes. Okay, thank you everyone. Sorry, sir. Nice you panchayati machram. Right, next week ABC turn only. We'll meet on next Friday. Anesthesia class.
Thank
Thank
you,
you.
Srikanth. Later. Thank you. All right.
Thank you. Sorry, sir. Yeah.